I am Dr. Shashi Vani. I am an Emeritus Professor of Pediatrics and Neonatology from PS Medical College, Karamsad, Gujarat. Earlier, I have been working as Professor and Head of the Department of Pediatrics and Neonatology from BJ Medical College, Ahmedabad. Yes, when we started as student, there were very few pediatric units in medical colleges, and even the posts of pediatric teachers were also much less. And very few institutions had independent pediatric units. So that was the status at that time. And many times even the public used to consider, after all, child is like a small man. So if you give one tablet 3 times in a day for an adult, at the most you will give half tablet or quarter tablet to the child. What is so special about it? But then gradually now we have learnt that pediatrics is a separate subject by itself and it requires special attention. And now we have come to a stage that not only pediatrics was recognized as an independent subject, but now subspecialties and super specialties in pediatrics are also coming up. That newborns also, we are dividing pediatrics also into neonatology and then children and then adolescents, and from there again pediatric gastroenterology, pediatric cardiology, pediatric neurology, pediatric intensive care, like that several branches have come. Almost all the branches have come with specialty, pediatric nephrology. To the extent now we are going even one step forward, that even in newborns also we have developed neonatal cardiology, neonatal pulmonology, neonatal endocrinology as subsets are coming up. And now we are going even further, fetology is also coming up and fetal therapy is also coming. So in our own lifetime, from a general pediatrics, now we have traveled to super specialties and subspecialties, and even in pediatrics there are so many divisions are occurring. In India, we took a long time to recognize that newborn requires special attention. It was because earlier our infant mortality was so high and our main causes were multiple infections and malnutrition. So as pediatricians initially we were fully engaged in tackling the problems of diarrheas, pneumonias, tuberculosis, various infections like even typhoid, malaria, hepatitis, and malnutrition, undernutrition, different deficiencies, anemias and these problems. To the extent that we were so much engrossed in that, newborn did not get so much attention from us. Then gradually, at least pediatricians and academicians, we did realize that newborn care is very important. But it took a long time for us to convince the policy makers to give the due priority to pediatrics, and that too for the newborn. We made several efforts even through the government health programs, that we introduced ORS program for tackling diarrheal problems. Then we introduced several nutritional programs. Immunization is one of the major success programs for tackling childhood infections. And through such programs, we have been able to reduce infant mortality, but it is mainly in the post-neonatal period. And newborns, they have different problems. So newborns require attention not only at the time of birth, but right from conception the care is required. But even at the time of birth, to ensure a safe birth, that itself has been a major challenge. We did not have facilities for hospital deliveries everywhere. Even today we do not have that much, but at least in recent years government has introduced institutional deliveries as a major policy and giving a lot of incentives for having institutional deliveries. But by institutional deliveries, at least we are ensuring a safe, clean delivery. But asphyxia becomes one of the major causes in neonatal mortality. Neonatal infections becomes another major problem, and low birth weight infants, and that too preterm infants, they constitute a major cause of mortality. Almost whether it is due to infection or asphyxia, but low birth weight, in that the problems are much more. So almost 75% of the mortalities occur in the low birth weight and preterm babies, and remaining occurs in the other babies. But all this information and knowledge we could accumulate only over the years when we started working with the newborns. And through our organization, this National Neonatology Forum and other newborn care organizations, we have realized it for almost last 3-4 decades. But only in a recent decade, after the Millennium Development Goal and such targets have been come, government has realized that unless it tackles the neonatal problems, it won't be able to reduce infant mortality further. And that is how now some attention is being given to newborn care. But overnight it may not happen because India has many challenges. In newborn challenges, we often say India has got so many world records which are not to be envied, but we have the world records. We have got the highest number of births compared to any other country in the world. 270 lakh births per year. We have got, and that constitutes almost 20 to 25% of the total global births. Then we have got the highest number of child deaths, neonatal deaths, which again constitutes almost 30% of the global incidence. Highest number of low birth weight babies. We talk about low birth weight babies separately because that is the most vulnerable group and prone for high level of mortality and morbidity. So low birth weight also, we have got almost 30% incidence of our own babies, and together they constitute almost 40% of the total births all over the world. So that is another major problem. And amongst the low birth weight also, in many countries it is the preterm babies which is the problem. But in India, 1/3 of the babies are preterm and 2/3 of the babies are full term but small for date babies, what we describe as intrauterine growth retarded babies. Why I am pointing this is, these IUGR babies are functionally mature, but they are malnourished. So their problems are little different, but comparatively they can be tackled in much less cost and much less expertise as compared to the preterm babies. So that is another area where we have lots of preventable causes which are happening. So that is another thing. Our stillbirth rate is also very high, and maternal mortality is also very high. So all these factors are making us make a grim picture in our national scenario. And as I told you, only in recent years now, after a long effort with so many professional organizations as well as pressure from the international organizations like WHO, UNICEF and others, now our government has taken up newborn care as a policy and gradually trying to introduce some of the help in this area. And now they are created health workers who are trained in newborn care, and then district level special care units for the newborns, referral services for the newborns, and some of the hospitals they have tried to give some extra additional help for the newborn care. But gradually at least some beginning has been made, but we have a long way to go. The first thing I would like to suggest is we have given the priority on paper, but it must be implemented fully. And another thing, we have a lot of inequities. Some states are doing very well, other states at the same time they are not doing so well. So accordingly we have to, and there is urban rural differences are also there, poor rich differences also there, state to state differences also there, and gender discrimination, that is a socio-cultural angle. So that is also there. So we have to fill up all those things, and only creating a patchwork approach may not help. It has to be a sustained long-term investment in the newborn care. Right now, government is taking up health workers on contract basis. They are taking the help of even non-medical doctors for this purpose. they are taking the help of community health workers, but it should be some permanent cadres have to be created, some special incentives will have to be provided so that these workers are motivated to work for them and then take up all the priorities, and they should take the professional organizations also in consultation. I am not saying it is not being done now. It is being done, but it is a little patchy effort. It has to be a little more sustained and properly planned effort to achieve the goals. See, there are multiple challenges as far as the community newborn care is concerned. We have some difficult geographical terrains also. Poverty and ignorance of the community is also there. And at the same time, government is, due to their own problems maybe, but they are not able to reach newborn care services to all over the places. So all these also constitute, and we also have to create behavioral change in the community. First of all, they have to accept whatever available services also, they should be able to utilize them fully. They should have faith in these services, they should utilize them fully, and then they should be able to come out with their needs. I'll just give you one example. Recently, government has introduced many incentive programs for institutional deliveries. By institutional delivery, we are aiming for a safe mother and safe child, at least clean delivery and immediate attention to the newborn. That is the objective. But the way in which the labor rooms are existing, they are not in a desirable position. So even if they take one agenda, improving the labor rooms everywhere. Labor room, I don't mean only the physical structure. Trained manpower should be there. All the equipment should be available. Maintenance of the equipment also should be done properly. Otherwise, equipment supply one time is there, but maintenance is very poorly attended to. Similarly, staff members they come, but there is a lot of mismatching. Wherever there are trained persons, equipment is not there. Wherever equipment is supplied, trained persons are not there. And at the same time, doctors also, wherever a trained doctor is there, all the support services which he requires. See, one doctor by himself, with all his enthusiasm, with all his expertise, how long he can sustain? He needs to be given at least 2-3 people in a group. I have been often saying, one doctor in one place if you put, they won't work much. Now they have prepared some ground plan for starting SNCUs with 4 doctors, so many nurses, so much of equipment. But again, so much manpower is also not available. So that human resource also, we have to find out how we can get them. Doctors may not go to the rural areas, they may not go to the tribal areas, but at least then we must have some other modalities by which we can get them. Road and communication, transport, then telephones, facilities, several issues are there. We need to tackle them. And now something is happening, but a long way to go. We have to have permanent staff, their training has to be there, and award and appreciation for those who are already working and doing work. That is also an important aspect. Otherwise, a person who is not working, person who is doing some work and person who is doing a lot of work, all of them are treated equally. Or sometimes the person who is doing a lot of work, no appreciation and no reward, but keeps on constant transfer, repeated transfer, no incentives, and it is a very, very, I would say, pitiable situation. So we have to have some mechanism of even awards and appreciations for those who are working even in the remote areas with minimum facilities, still showing some results. That itself will become an incentive for the doctors to do a work. Some states have introduced a system for those who are doing this rural service, they give them the seats in the post-graduation. They give them the priorities in some of the specialty trainings. So these are all some of the methods by which they attract trained people for the community work. But at least some such incentives should be available everywhere. So these are all a few suggestions. And another thing happens is pay of the staff members. It will never match with what they get in the private hospitals. So naturally sometimes they get training through the government and then they go away. It becomes a best export commodity. They go to the Middle East, they go to the health centers. So government also has number of challenges, but once at least recently they have taken it up on priority. They have taken up somebody. So they should accord one separate section for newborn care. And similarly, all the states also should have one person who coordinates the newborn care activity. In states like Tamil Nadu, they have one. In Kerala, they must be having. So in those states, newborn care gets a lot of more attention. Some of the states, the same person does for the women, same person does for children, same person does for adolescents, same person does for tuberculosis, everything. So naturally a person cannot meet all the requirements. So these are all some of the issues. Then data collection, research, epidemiological studies, all these also have to develop. See, from time to time, depending on whatever was the need of the hour as we felt it, we have been trying. Like way back, I am talking in 60s. Initially, we realized our vaccination programs. That time, government had not introduced immunization programs, but we started immunization services in our department and started motivating people to accept immunizations. Even we had to import vaccines from outside. Through donations, we have done that. So immunization services were started. Later on, ORS promotion, that is oral rehydration salt and solutions for diarrheal diseases management, and that was started. Then nutritional education and nutritional supplementation services, nutritional rehabilitation services, they were started. And all these along with our regular curative services like intensive care, emergency care, all the different services. This was also as a parallel line we developed. And then subsequently expanded program of immunization came, then universal immunization program came. Then we monitoring the immunization services, monitoring for the adverse effects following the immunizations. All these we started long before the government started it as a general program. And then we entered into some of the child health programs of the government like Integrated Child Development Services, then IMNCI program, then RCH program, CSSM program. So whatever government services where government programs were introduced, there also through the department we participated. And very few departments in India, they give equal attention to community pediatric activities also. So that is another major gap we need to fill up. So only on curative part we go, or we go where a lot of money making things are there. Today if you organize a ventilator care workshop, people will come. But if you organize a kangaroo mother care workshop, not many takers are there. So that also has played a lot of part. And recently in newborn care, we introduced district level training program for the newborns. We simplified some of the newborn care activities according to the level of expertise available at the different level. So whatever a district doctor is able to do, accordingly we train them. Whatever a community nurse can do, we trained her accordingly. So now we are coming up with some of the, then breastfeeding promotion, that was another major program was taken up. We trained a lot of people, we started lactation clinics, and recently now at least I am concentrating on kangaroo mother care. We introduced that as a part of WHO program of thermal control. And as a measure of preventing hypothermia, kangaroo mother care was introduced at that time by an international group, and we entered there as a part of the multicentric study. And then we started the first kangaroo mother care ward in our department. Subsequently, because I had retired for a few years, I was not in it, but during that time, All India Institute of Medical Sciences and then Chennai, Lucknow, Jaipur, all these centers, they started kangaroo care units, Mumbai also, and they formed an network, and they were trying to start some guidelines, manuals, prepared some teaching CDs. We started some of our first studies, and then we found out not only as a measure of preventing hypothermia, but it increases the breastfeeding, it increases the growth rate, and several other things. Then I became a part of the International Kangaroo Care Foundation. In 2012, we organized the first International Conference of Kangaroo Mother Care in Ahmedabad. And that is the time, again we requested Government of India representative to attend. Kangaroo Mother Care was being pushed to government to take up as a program, but our international conference became one of the catalysts, and subsequently following that, Government of India has introduced that as an independent program in the government programs and included it in the government policy of recently formed India Newborn Action Plan. There also Kangaroo Mother Care has become as one of the important part. And recently in the last August, we have launched an independent non-profit voluntary organization, and we are calling it as Kangaroo Mother Care Foundation of India. Our main objective is to create awareness about kangaroo care. We want to increase the training programs, and then wherever kangaroo care is being practiced, we want to improve the quality of practice and take it to higher scales, and even take up some of the research activities, whatever is possible for us. ICMR also, we requested them to take up some research programs on kangaroo care in community. So they have taken up one study where we were also participants. So like that, gradually now we are making inroads, and this kangaroo care network, they had also made in some progress. But still we find, we had taken a survey also. I had done one survey during the conference, and then after that Dr. Rekha Udani, she also did one survey with the help of Save the Newborn Lives of Bill and Melinda Gates Foundation with their help. She studied in 10 centers, and we find still barely, this is just a rough estimate, only 5% people are still practicing kangaroo mother care, and that too wherever it is being practiced, there also a lot of quality improvement is required, and we need to spread this message, training and actual practice to all the parts of our country, because it is estimated that only if minimum of 90% coverage of these activities are there, these simple interventions like breastfeeding, kangaroo mother care, hand washing and such simple interventions, if we can achieve and reach up to 90%, then the impact will be felt. Lancet, it is a leading journal in UK. They had organized a world expertise group to study about the newborn care situation in the world. And in 2005, they released 4 articles on newborn survival in the global level. And in that also they have put evidence-based report that breastfeeding promotion, if it is done properly, it has the highest potential of reducing newborn care. And along with breastfeeding, if kangaroo mother care is also introduced, that also multiplies the effect. And simple methods like hand washing and then neonatal resuscitation, tackling pneumonias, all these simple things which are doable at community level, even with our available resources today, if we can reach it to 90%, even without ventilators, surfactants and all the high-tech things, we can bring down our neonatal mortality substantially. And of course, if some additional services like simple oxygenation, IV fluids, antibiotics, phototherapy and some such simple measures which can be introduced, if we can give, we can bring down the neonatal mortality even more. And barely 3 to 5% of the babies only require high-tech, sophisticated, technology-dependent, specially trained doctors and equipment for the intensive care of the newborn care. But this is the situation now. We have started a lot of intensive care units, but again they are all only commercially viable. Government set up very few ideal intensive care setups are there, and level 2 nurseries also all the medical colleges are not having. Now some of them are increasing, but still they are not having. And primary care also some efforts are being made. So patchy efforts are being made and long efforts are